So our next presentation will explore recent updates in the outcomes of anti-seizure medication exposure during pregnancy. Dr. Raluca Pana is a neurologist and epileptologist at the Neuro and Assistant Professor in the Department of Neurology and Neurosurgery of the Faculty of Medicine at McGill University. She obtained her Doctor of Medicine from Université Laval, followed by postgraduate degree in neurology from McGill University and an Epilepsy Fellowship from the Cleveland Clinic Lerner College of Medicine. Chun Ip Koo is a clinician nurse who works at the Neuro since 2011. She obtained her Bachelor of Science in Nursing at UdeM, followed by her Canadian Neuroscience Certification. She was a bedside nurse on the Stroke Unit and Neurosurgery unit. She became the Epilepsy Clinician Nurse in 2017. She attended different conferences such as the American Epilepsy Society, Canadian League Against Epilepsy, and Canadian Association of Neuroscience Nurses Conference, enriching her knowledge in epilepsy and to share it with her peers. So welcome, Dr. Pana and Chun Ip Koo. Should be the latest one. Like I just uploaded.
It's okay. If not on my laptop. If not on my laptop, I'll connect. Hi, thank you so much for inviting us today. So I'll start and then I'll pass it over to Chunip. That's okay, but you're welcome to ask us questions. Usually we like this to be a bit more interactive, but I'll present mostly literature, but you're welcome to ask questions along the way. So the objectives of the talk are usually really to become familiar with the complications associated with epilepsy and pregnancy. That's going to be a little bit less the focus today, and really more the focus is the complications associated with the anti-seizure medications that we give to our patients, as well as the strategies to mitigate potential complications of the unborn child and the mother using medications during pregnancy to prevent seizures. So although we're going to talk mostly about pregnancy, it's very important in our practice. It's mostly outpatient, and it's very important to plan pregnancy. So that's the number one lesson of the talk today. If you're going to remember something, is that at any point when you encounter a patient, a young woman specifically with epilepsy, it's important to really talk about pregnancy planning, contraception with this person, because oftentimes they're going to be taking treatments for their epilepsy for a long time. And at some point they're going to decide to get pregnant. They may make that decision in between appointments. And some of our medications are safe and some are not safe. And so I think any contact with the healthcare provider is important, and everyone should be aware of potential complications of our medications and treatments. And that's why I decided to choose this topic today. So before we talk about pregnancy, so it needs to be planned, and for it to be planned, you need to talk about contraceptive use. And there's a lot of anxiety as well from other healthcare providers about what contraceptives are safe in combination with our anti-seizure medications. And so I'm going to be briefly touching on that today. So we generally say that pregnancy must be planned at least 1 year in advance. Does anybody know why we say that? No. Okay. So it typically is because pregnancy, the course of pregnancy so in terms of seizure control, will be reflected in the year prior to pregnancy. So 9 to 12 months. So if you didn't have any seizure 9 to 12 months before the pregnancy, you're not likely to have seizures. So you have good control 1 year before, you're not going to have seizures in your pregnancy. If you have really a lot of seizures, you're badly controlled, well, you're probably going to be badly controlled. So at least 1 year before we should have that discussion. And it also gives us time to plan for the right medications. And so in terms of contraceptive use, there's a lot of interactions with the medications and the hormonal contraceptives. And that particularly is for enzyme-inducing anti-seizure medications. And that's because they usually enhance the production of enzymes in the liver, and so you can metabolize estrogen and progesterone faster. So the oral contraceptive medications will be less effective. So it can lead to contraceptive failure, unplanned pregnancy, and also teratogenicity if you're on medications that are not as safe. Other problems with some of our medications. Do you all know what valproic acid is? That's one of our anti-seizure medication. I say anti-seizure medication, but really they're used for migraine prevention. They're used for bipolar disorder as well. And so valproic acid, for example, is implicated also if you use it since the woman is very young in polycystic ovarian syndrome, and that can lead to infertility as well. So it's important to consider these factors early on. So I'll give you some examples. So not all anti-seizure medications are involved in producing interactions with hormonal contraceptives. So the ones that are inducers are listed here. So that means that they're going to reduce the effectiveness of your oral contraceptive pill. So we typically recommend a second, like a barrier, like let's say condom, for example, like a barrier contraception along with the oral contraceptive pill. If you're on one of these medications, there's one that's not on there. It's cenobamate, which was recently introduced on the market, though it's difficultly available, and we don't recommend it in pregnancy anyway. But anyway, so cenobamate should also be here. It's a strong inducer. So if you're going to be on that, we recommend that you're on oral contraceptive medications that have at least 30 micrograms of estrogen. Typically, we say 50 micrograms, and most pills these days have a little bit less than that. So it's not a great idea, but sometimes we do it. These are the ones that are safe with an asterisk, because sometimes the estrogen can decrease the efficacy of valproic acid. So there's interactions. Okay. So this is another way of looking at it. It's a bit more palatable. So the strongly interacting anti-seizure medication, so carbamazepine. If you see a patient that's on carbamazepine, you're going to see less and less young women on carbamazepine, but you might still see them. This one has the cenobamate here. So these really have a lot of interaction with oral contraceptive medications. We try to avoid that, and we're going to recommend IUDs instead, and I'll show you which ones. The mildly interacting, so these, you'll see a lot of women on lamotrigine because it's safe in pregnancy. So that's one of the ones that we're going to use a lot in young women of childbearing potential. So this one is not interacting, except if it's at a high dose. Then it can decrease the efficacy of your oral contraceptive medication. Same thing with topiramate. It says mildly interacting, so it's above 200 milligrams per day. And this one, if it's above 300 milligrams per day, so those are slightly high doses, it can still interact. And then the ones that are non-interacting, these are the ones we use a lot. You'll see that a lot of patients are on levetiracetam or Keppra. So levetiracetam is here. So we do like it because it doesn't really interact with anything. Okay. So when we say enzyme-inducing anti-seizure medications, because they interact with the CY3A4 system, and that's the one that metabolizes estrogens and progesterones. And that's important to keep in mind that they metabolize both. So it's not just estrogen-containing oral contraceptive medications. Sometimes even if you have progestin-only pill, they will decrease the efficacy. So some of the symptoms that you might see, for example, if you see a patient who you just started on enzyme-inducing medication like carbamazepine, and they were on a mini pill, like on a progestin, is they may have a mid-cycle bleed. That could be a symptom that they're having, that they're failing their contraceptive. So we usually work in combination with gynecologists. It's not really my specialty, but some of the things that might ring a bell. If a patient tells you that, oh, I had a bleed, I didn't used to have that, I just started an anti-seizure medication, well, you should think, oh, there's an interaction there. Probably you should change your type of contraceptive, or maybe we should consider a different anti-seizure medication. The luxury of our specialty is that we have a lot of treatments for epilepsy, so we have the luxury of being able to change the medications. So contraceptive failure, just to give you some numbers, I mean, in the literature, I don't know, I keep telling Chunip, we don't see this in our practice, so maybe Canadians are better than the Americans. But in the literature, we see unplanned pregnancies from 30 to 50% rates in our patient population. So I always tell my patients this. Thankfully, our patients are good and they plan their pregnancies with us, but we have to follow the literature. So we do counsel them regularly. And so just with oral contraceptive, the contraceptive failure rate is around 7%. And so there's a inverse relationship. So the contraceptive can affect our seizure medications. And so that only happens with lamotrigine and valproic acid. It's rare that young women are on valproic acid, but they can be on that. So what we can do is, thankfully, they're both, we can measure them in the serum. And so what happens is that we can adjust the levels. We just have to be careful when we remove the oral contraceptive pill because the levels can fluctuate and patients can have seizures. And so our firm recommendation really for all our patients is really to put an intrauterine device. These are good for about 5 years and some really up to 8 years. And so here we have mostly Mirena, but there's another one, Kylena. They have levonorgestrel. So that's the hormone, but it's a local hormonal effect. It's not systemic. And so it's not going to be prone to the same interactions as if you take a pill by the mouth. And so there's no interactions. There's not a lot of studies, but there are some pilot studies that show that when you take an anti-seizure medication, it doesn't, and you have this hormonal and producing intrauterine device, you don't have changes in your serum level of anti-seizure medication, at least with carbamazepine. That's one study that we found. And so in summary, before a woman gets pregnant, so at least 1 to 2 years before, but really at any point where you have, starting at the time that a young woman gets her period, really we should start having these conversations about, you start anti-seizure medication, we start a medication that's safe in pregnancy, and I'll be discussing those in a little bit. And then we start talking about contraceptive methods. If it's a medication that it's an enzyme inducer, I showed you the list earlier, we usually recommend an IUD. And if not, then, if you really have no choice and the patient refuses, sometimes they don't want an implanted IUD, then we recommend either the cervical ring, the patch, or the pill, but with a higher progestin dose, plus a barrier method. So really 2 contraceptive methods. If it's a non-inducing anti-seizure medication, then they can use the oral contraceptive pill. An IUD is also fine. And in terms of emergency contraceptive, so that's like the plan B. So we just have to keep in mind that patients who have enzyme-inducing anti-seizure medications, they need double the dose of the plan B. So they typically have to take a second dose 6 hours later. Pharmacists usually are aware of this, and they're often the ones dispensing. But if ever you come into contact with our patients, they're on carbamazepine, they may need that second dose. Otherwise, their plan B might not work. Okay. So in terms of the other things, so right before, in terms of pregnancy planning, so we often recommend women to be on folic acid. So what we don't know is how much folic acid to recommend. There's a lot of controversy about how much. We typically recommend either 1 milligram or 5 milligram. People always ask me, is it okay if I take the Materna, like the vitamins? So typically Materna, depends on the brands, but usually if you look, it's around 0.4 milligrams. We recommend between 1 and 5. So I still give the 1 milligram for our patients. There's no agreement on dose. A lot of people used to recommend a higher dose if you had a history of neural tube defects in previous child, or if you have a personal neural tube defect. So for example, if you have spina bifida, then you have a higher risk of transmitting it to your child. So then we recommend a higher dose in that case, or if your partner has a neural tube defect. So some societies recommend higher doses if you're on some medications that are known to have higher rates of teratogenicity, like valproic acid or carbamazepine. There are higher risk of giving neural tube defects. So in that case, some physicians will choose to give higher doses. The American College of Obstetricians recommends it if they just say high risk of NTDs, which goes back to what I was saying. So really, it's a case-by-case decision. The problem is that we know that giving folic acid supplementation in pregnancy prevents neural tube defects, but we mostly notice in the general population. We don't have a lot of studies showing that in specifically patients with epilepsy, it reduces or it counteracts the teratogenicity from the anti-seizure medications. And so this study here that I'm quoting is really in the general population. And we know that, for example, valproic acid exposure gives teratogenic effects, but it's not necessarily through the disruption of folic acid metabolism. So giving folic acid is not going to be the only preventive method to having neurotube defects or to having teratogenicity. The only thing that we do know about folic acid supplementation is that actually, there's a couple more studies that show that if you give folic acid supplementation in women with with epilepsy who are pregnant, their child tend to have a neurodevelopmental benefit. So it's really an improvement in the IQ in the child. That's what we see. And actually, they looked at there was one study that showed that it was the supplementary folic acid, like the vitamin, that showed that benefit in IQ when they looked at the child at 3 years and not just eating more, for example, folic acid in your diet. So really, you needed higher levels of folic acid to prevent, for example, autistic traits in your child. So that's the benefit that we see. And there was another Danish study, for example, that showed that they looked at children up to 8 years old, and those children had 5 to 8 times less likelihood of having autistic traits, so not autism per se necessarily, at the age of 8 years old if they took folic acid supplementation. So that we know for sure. So higher IQ, less autistic traits. That's the evidence is showing us. So that's why we give it in our patient population. So in the general population, of course, and that's why it's for NTDs, and we give it, of course, for that too, but we don't have the literature yet to support it in our patient population. You look surprised. Any questions so far? So what's the harm? Because people say, oh, it's a vitamin, why not just give it? So there's been a lot of debate over the years as to how much and why not give it. And so recently, actually in 2022, this led to a lot of controversy as we have a study, I believe it was also in the Danes, right? And then Danish, in the Danish, yes. 27,000 children born to people with epilepsy who were exposed to higher than 1 milligrams per day of folic acid. They were associated with higher risk of childhood cancers before the age of 20 years old. And so this led to a lot of phone calls in our clinics. You know, I'm on 5 milligrams. Is my child going to have cancer? Because, you know, patients are very aware of the literature. And we also had a lot of questions as to how much counseling we need to do about this. And so the conclusion is that, and I can show you the study here. It's in JAMA Neurology in 2022. This has not been replicated yet, but you can see here that if they were so they followed the children up until 20 years old, and they looked at the incidence of childhood cancers. If you were having high dose folic acid, it's the orange line. If you didn't have a high dose folic acid, so above 1 milligram per day, then you were on the blue line. And this is particularly in mothers who had epilepsy taking high dose folic acid. They didn't really see that same trend, although maybe a little bit, but at least they conclude that they didn't see this trend in patients without epilepsy. So it's something in our patient population with high dose folic acid that seems to correlate with higher incidence of childhood cancers. We don't fully understand it. It was an observational study. It's an association. It doesn't mean it's causation. But we are very careful since then in prescribing high dose folic acid because we're not sure of the benefits, right? We're sure of the benefits through neurodevelopmental outcomes, but unless someone is at high risk of neural tube defects or they're on a medication that is associated with neurodevelopmental or poor neurodevelopmental outcomes in their child, we won't give high dose folic acid. And more studies are ongoing since then. And then the other thing is that it can decrease levels of phenytoin, although very few women are on phenytoin in pregnancy, but something to keep in mind. And something we struggle with is adherence. What happens is we have to prescribe it to every woman who's in childbearing age potential. Someone who's controlled, we see them once a year, every 2 years, and then they're not taking their folic acid and they come back and they're pregnant. So you have to take your folic acid at least 3 months before you conceive to protect against neural tube defects. So it's important to really take the folic acid, and that to reinforce taking the folic acid is difficult. Patients don't know what they're taking it. They're like, I'm not getting pregnant now. And we have high rates of unplanned pregnancies. So that's a little bit our challenges in our practice. And now apparently it causes cancer. So that makes things even more difficult in terms of adherence. So we're working on that. So before I continue, I wanted to share a case study and also to break the boredom of showing you a bunch of medications and studies. This is a case that I had in my practice a couple of years ago. I still have time. I tend to go over time, sorry. So just to illustrate a little bit some of the debates that we have in our patient population. So I illustrated the problem in the preconception period. Now, this is a typical referral that we get in our patient practice. And some of the things you have to consider when you see these patients. So this was a very nice lady. She was 29 years old. She was right-handed. She has epilepsy, or so I'm told. She came in at 11 weeks pregnant. So far, I was told the pregnancy was going very well. She's taking topiramate, 25 milligrams twice a day. You're familiar with topiramate a little bit? Something we use for migraine prevention, for epilepsy. Some people use it for mood disorders like bipolar disorder and also for neuropathies, although it doesn't work so well for neuropathies. And she had had a previous pregnancy on topiramate as well, low dose. So typically we go up to 100 twice a day for epilepsy. This is a very, very low dose. She also had obesity, so I could see why they chose this medication. I thought maybe it would help with her, and she had migraines. So I could see why the choice of medication was made. She was referred to reassess this anti-seizure medication due to the fact that she was pregnant. Does anybody know what some of the problems are? Or some questions you might want to ask her? Yeah. Okay. Yeah. What are you thinking?
That a previous child?
Yeah.
Just a question in the chat. If she's already 11 weeks pregnant, are there not risk of changing ASM at this point? Question mark.
Yeah. So these are all things to consider. So you bring up a very good point. So obviously I put that there for a reason. So her child has autism. I found that very interesting. Does anybody know why? I'll get back to the changing anti-seizure medication because that was absolutely my debate. Should I change it or not? And why would I change it? Does anybody know what I'm alluding to? Yeah, so is there an association of topiramate with autism? So that's what I'm getting at here. So do we use topiramate in pregnancy? Do you know? Okay, so those are all the things to consider. So first of all, those are all things that were going through my mind. Of course, she's 11 weeks pregnant. So changing in pregnancy is always debatable. So the first thing I did is I got her records. I mean, obviously, this is something whether you have time or not, sure. I made a decision before I got her records, but I still got her records to confirm. And she did, in fact, have epilepsy. She had bilateral tonic-clonic seizures in sleep. It was convincing, but she had a very mild epilepsy. And it was many years ago that she had her last seizure. I didn't put it here, but she had her last seizure at least 5 years before. and the last pregnancy, she had no seizures, and she had no seizures before her last year, before she was pregnant right now. So extremely well controlled. Her EEGs were normal, MRI was normal. That doesn't mean she doesn't have epilepsy though. So some of the things to consider when you see a patient like this. So first we have to confirm the diagnosis. That can be already hard if she's already 11 weeks pregnant. It might not be the right time to do that. And then the teratogenicity of her anti-seizure medication, the timing in pregnancy, which are all factors that you've mentioned. So I'm going to go through some of this evidence, and Chunip will go through some of this evidence. And I'll tell you what happened to the case a little bit later on. So what are the anti-seizure medications that are safe? So you guessed it. The reason I put this case here is because she's on an anti-seizure medication that's not safe. Although here it's not that apparent, but so these are, just to explain the graph a little bit, we have international registries where women up until 10 weeks of pregnancy, they call these registries, and then they're followed until the child is about 2 years old, and they look at malformations. They didn't used to look at neurodevelopmental outcomes. It was mostly looking at cardiac malformations, cleft palate, really physical things mostly. And so we have thousands and thousands of women that have put themselves on this registry. And we've come up with rates of major congenital malformations with each medication, depending on which each registry that reported it. So this is the European one, the circle, the North American one, and the UK in the square here. So the safest ones that are considered for pregnancy are levetiracetam, which is Keppra, lamotrigine, and oxcarbazepine. We use these for generalized epilepsy, and this one for focal epilepsy. The main point here is that, and the rates of malformations are between 2 and 3%, depending on the registry that's used. Just to give you an idea, a woman that's not on medication that has epilepsy, her rate of major congenital malformation is between 1 to 2%. So it's about double. Okay. So valproic acid, depending on the dose, you're closer to around 10%. So this is the one that we absolutely want to avoid. We don't like phenobarbital. As you see, it's much higher. Phenytoin, also, we don't tend to use it. Carbamazepine, it depends on the registry. If you look at the European one, it can go up to 6%. And topiramate is not great, but mostly because it was shown to have high rates of cleft palate abnormalities. And we'll talk a little bit later that, yes, in fact, we did see some neurodevelopmental outcome changes, mainly autism, with the use of valproic acid and topiramate, but Chunip will tell you a little bit more about that. So it is dose dependent. So if you have to use valproic acid, we tend to, so you see it's around 10%, or it can be even higher than that depending on the dose. But if you go below 650 milligrams per day, it goes a little bit lower. So in generalized genetic epilepsy, sometimes we don't have a choice. It's the only thing that controls the seizures. And so if we have proof that it's the only thing that's ever worked, we consent the patient and we just keep the dose really, really, really low. So there's some strategies that we can use. So I don't have a dose for topiramate. We don't have this data for all the medications, unfortunately. When we have it, we counsel the patients with that. So do we change during pregnancy? That's a great question. Generally, no, because we don't want to rock that boat when someone's pregnant. And so the other thing is that usually most of organogenesis by 11 weeks is done. So, we're not going to change the medication, especially a new patient like this that I don't know. I don't have a lot of history. I was very hesitant to change the medication. The only problem was that, she hadn't had a seizure in 5 years. So the first question is, does she really need a medication? Could I take her off medications? And the dose was so low, so does she need it at all? And I'm going to steal the punch a little bit from Chunip. So there is a risk of autism, and she had had a child with autism before with topiramate. So that was my main concern. And we don't know at which point in the brain development of the fetus that occurs, because we don't fully understand it. So there is an argument then to take her off topiramate just for that reason. And the other reason to change anti-seizure medication is, if they have multiple anti-seizure medications and you know by history that they don't need it, or you have the wrong diagnosis, for example, they have pseudo seizures, and you document that during pregnancy, although you don't have that much time to do all that work. But if you manage to do that, there might be time to remove it. Or if they're on valproic acid and you know that you could have other options. However, again, generally we say the answer is you shouldn't change anti-seizure medication. And there's actually some studies that looked at, as I told you, generalized genetic epilepsy. Valproic acid is the best medication. We have numerous studies that show us that. It just outperforms the new medications like Keppra. We just know it's better. And they've looked at whether if you remove valproic acid, the patients will have more generalized tonic-clonic seizures, and it generally is twice as common as just maintaining the patient on a low dose valproic acid. The problem is that the only type of seizure that we know causes harm to the fetus and to the pregnant woman is generalized tonic-clonic seizures. The other types of seizures we don't know. Like if you have an absence seizure, if you have a focal impaired awareness seizure, you can injure yourself, you can fall down the stairs. So of course they're dangerous. We try to treat them, but we don't know that the seizure itself is dangerous to the fetus. Whereas a generalized tonic-clonic seizure, we know there's changes in oxygenation. We know it's associated with abnormalities. So in general, we don't try to change the anti-seizure medication. I'm gonna let you take over here, and then we'll talk about what I did with my case at the end.
Okay. So now we're going to look a little on the neurodevelopment outcomes with anti-seizure medications exposure. So the two poor neurodevelopment outcomes that we're going to focus on today, it's mainly on autism spectrum disorder and the intellectual disability, sorry. And usually these diagnoses are done in the child by the child psychiatrist and psychologists. So this is a study of the neurodevelopment effects of anti-epileptic drugs. So basically the researchers in this study, they followed children up to 6 years old, and they conducted tests to evaluate their cognitive outcomes. And the primary outcome that they looked at, it's the intelligence quotient. And basically, if we see here, the solid lines are basically the children who were exposed to folic acid perinatal, and the dashed line here, it's basically children who were not exposed to folic acid. And in the different medications that are exposed to the seizure medications that are exposed, so we can see that there is actually a better outcome if we are exposed to folic acid. Here with the valproic acid, as we know, basically they're associated with higher risk of like IQ, poor IQs and things. And we see that there's still slight improvement with folic acid. And then this is another study that was look at the registry by the Nordic countries. And what the conclusion they saw was that topiramate and valproic acid was highly associated with autism spectrum disorder and intellectual disability. And they saw that the dose that basically the medication dose, the higher that we use, the risk is increased. And there's not really any changes if we decide to use one medication. Basically, when we choose to use two medications, the risk of neurodevelopment disorder is the same, except for if we chose the combination of Keppra and lamotrigine. And to show this a little more clear, we'll look at the graphs here. I don't know if it's clear enough. So here, the first column here, it's basically children who were born to women with epilepsy. So they were exposed to medications, and each color of the line, it's the medication. And as we see, the gray one here, and this one is the, I think it's the topiramate. Yeah. And the orange one here is the valproic, the valproic acid. And this one basically is for the autism spectrum disorder. And we see that with those two medications, the risks are higher. The intellectual disability for the valproic acid here is higher. I don't think there was a study for the topiramate on this study for the, I don't see the, no. And basically, they look at the two, and we see that there is increase with the valproic acid and also with the topiramate here. And this is just a study that they looked at children who were from the general population who were also exposed to seizure medications, but not born to mother with epilepsy. And it's the same kind of conclusion for valproic acid, that there is a higher risk of autism spectrum disorder. For the intellectual disability, it's the same. And here we see the same pattern that increases. And if we looked at the combination of therapy, so when we use one medication, the incidence of the risk is lower. And at the bottom here in the red table, square, sorry, we see that valproic and lamotrigine, the incidence increases to 5.5, lamotrigine and trilepto goes to 4.3. And as you see the numbers here, and if you look a little upper here, lamotrigine and Keppra, as we said, is actually a safer choice. The incidence here is 1.6. And this is also results that were on children who were born to women with epilepsy. And then this is the general population of children who were exposed to anti-seizure medications, their mom who did not have epilepsy. And the incidence for lamotrigine and Keppra is actually the same, 1.6, compared to the other population as well. And then we see here for the same for valproic, lamotrigine, trilepto, etc. And then here we can look at the different doses of the incidence. So for lamotrigine, if we use less than 150 milligrams, the risk of having a neurodevelopment outcomes is 1.46. And if we increases the dose to more than 150 milligrams, it's quite similar. It's actually, sorry, this is more than 150, sorry. And this is less than 150. Oh, no. I'm confused. No, sorry. So it's quite, and then for the carbamazepine, if we use less than 500 milligrams, it's 1.74, 1.48. And if we look at valproic acid, it's very dose dependent. So we see that if we are in the lower dose with less than 750 milligrams, the risk is 2.27. And if we the dose increases to 750 and more, the risk is actually quite doubled. It's 5.64. And then for the other medications, it's quite similar, the trilepto, carbamazepine, lamotrigine. So what we recommend, the researchers recommends basically is that when we choose medications, we try to choose medications that are less teratogenic. So the Keppra, the lamotrigine, and the trilepto. We try to use the lowest dose that can control the seizures of the patient. It would be preferred to use monotherapy, so just one medication, and to minimize the convulsive seizures when they're pregnant. And then do we have to do blood tests on women when they're pregnant? So usually the recommendation is that we do baseline levels when we know that they are pregnant. And then the ideal situation is to do levels every month and until up to 6 weeks postpartum. And then we would also recommend immediate blood tests if they report like increased seizures, or if their seizure severity change, or if they report any side effects of medication such as dizziness, blurred vision, because we want to make sure they're not on medication toxicity. If some medications that they use are not measurable, like Keppra, so the recommendation that we would say is that in the first trimester, we would most likely increase the dose of Keppra if the medication is something that is cleared fast by the kidneys, so such as lamotrigine, Keppra, and trilepto. So these medications, we know that as pregnancy increases, the clearance increases as well. So the dose that they take basically won't be enough to protect them from seizures. So usually we would increase the dose of these medications during pregnancy. And it's usually, I think, at the 5 week that we see the decrease of the clearance. So at that point, most of the medications will be increased quite a lot. If the patient is also known for a history of having convulsive seizures, we would already increase medications to protect them. Or if we know that in the past they were very sensitive to levels fluctuations and they would have seizures with that, and then we would also increase their medications. And if the patient is already on a low dose of medication when they are known, when they were found out to be pregnant, then most likely we would also increase the dose of this medication. So a little about the delivery. So most women can have a normal, safe vaginal delivery. The recommendation is to have Ativan IV at bedside during the delivery, and something to remind and to be like, sorry, I'm losing my words. Something that we should not be worried too much is that if the mother does have a seizure during the delivery, and we see that the fetal heart is actually depressed, it's normal. It's something that's going to happen temporarily, and after 5 minutes, it will go back to the normal. So it's something that will occur and not to be too worried about. And then after the postpartum period, so usually because we increase so much of the medications, the women might be having side effects. So usually we would recommend to decrease the medications to their pre-pregnancy level in 2 to 3 weeks. And for the lamotrigine, usually what the team that I've worked with, like Dr. Pana, usually she already prepares like a prescription for the patients so that they don't have to worry about calling us and to change medication. So we'll give them medications, usually like increase lamotrigine to a certain dose. And after delivery on day 3, day 7, day 7, day 3, 7, and 10, how to decrease the lamotrigine back to their pregnancy dose. And we would usually add 50 milligrams of the pre-pregnancy dose because we know that with mother, they might be sleep deprived, a baby will cry a lot, and sleep deprivation is one of the big factors of seizure occurring. So usually we give them extra medication just to protect them during this period. And for the other medications that are metabolized by the cytochrome P450 enzymes, usually they would be tapered down over 6 weeks. So carbamazepine, Dilantin, those medications we would taper down slower.
It's not as clear how fast to go, and we go depending on patients. The lamotrigine is the one that's been mostly studied because it's one that we use a lot, and we can measure. So that's the one that's why we have a recipe. The rest, it's kind of we case by case.
And then the little word about breastfeeding. So usually what we educate our patients is that breastfeeding, the medications can penetrate through breast milk. So here, Primidone and Keppra, they probably penetrate through the breast milk. And we're not sure about the amount, but there is probably some that goes through. Gabapentin, lamotrigine, Topomax, they can also possibly penetrate through the breast milk. As for valproic acid, phenobarbital, Dilantin, and carbamazepine, they don't penetrate. And basically the recommendation is that breastfeeding is recommended, and we'll show you here some studies that looked into it. So one of the main reasons why is, even though we know that the medications pass through the breast milk, the dose that they get compared to when they were exposed during gestational is actually lower. So it's quite safe. And then here we know that some medications who has minimal protein binding and great lipid solubility tend to distribute more evenly, more fast into breast milk. But from the NEED study that we looked at earlier, they also looked at the effects of breastfeeding women with basically the kids who were breastfeed compared to the ones that were not breastfeed. They actually show that the IQ is actually higher for the population that the mom has breastfeed. So they are exposed to some seizure medications, but their IQ compared to the one that were not breastfed is still significantly higher compared to the one that were not breastfed.
And there's no adverse events.
Mm-hmm. And then what we usually tell our patients how to care for children with their baby. So because of the risk of having seizures, we usually recommend them to change babies on the floor. We would tell them to feed their baby either on the couch or on a padded floor, or in the middle of the bed. We usually ask them to be around with someone or the husband or another family member when they are bathing the baby. If they're alone, usually we would recommend them using a stroller, try to avoid walking with the baby for long periods, or try to avoid going up the stairs. So if they do have like different stairs, we would tell them to bring most of their things that they need for the baby to one floor so that it avoids them to going up and down with baby. We also, if they have like an older child, well, we recommend them to maybe teach that older child what to do, how to recognize that the mom has a seizure, and what to do in case of emergency, who to call, what needs to be done. And for sure, we need to keep medications out of the children. And if they have any glass furniture or they have furnitures that are with sharp edge or hard edge, try to protect them or even remove them from their home. And conclusions.
Right, so maybe before we conclude, I'll tell you, I mean, are there any questions so far? Or- No? No, okay. It's not higher. It depends if they have, if they have multiple seizures or there's fetal distress, we defer really to the obstetrician. So sometimes they do ask us, if we think that the delivery is safe, unless they're extremely uncontrolled or they have multiple generalized tonic-clonic seizures at the time of delivery. I've not yet recommended. Yeah, there are. So we didn't talk about complications. The reports vary in terms of rates of complications, obstetrical complications. It's not clear. There is a slightly higher rate. We don't like to talk about it too much. There's a slightly higher rate of mortality in women with epilepsy during pregnancy. But that's really, again, from the Nordic countries and the UK as well. And the rates vary, So I saw one study from 6 times higher, another study is 11 times higher. So we don't fully understand why, So it's the same reasons, it can be, bleeding, it can be amniotic fluid embolisms, pulmonary embolisms. The cause of death are the same. And then some of the deaths can be from, they can be during pregnancy, it can be postpartum period. And if you look at the causes of death, sometimes it's suicide, sometimes it's, injury is rare. And then sometimes we wonder if it's sudden unexpected death in epilepsy, which is something that can happen in our patients. But those numbers are very low compared to the general obstetrical complications. But the literature is not really that consistent. So in general, when we look at the systematic reviews, the guidelines from the American Academy of Epilepsy and American Epilepsy Society, we counsel our patients that about 96 to 98% of our patients have good outcomes, good obstetrical outcomes. And that's the consistent literature, but worldwide, there is that tendency towards increased mortality. So we keep it in mind.
Just a question in the chat. Are there any other prenatal implications that you counsel epileptic women on? Ketogenic diets, B12 or iron deficiencies, etc.
During pregnancy, or I'm not sure I understand the question.
It says prenatal implications. So yes, during pregnancy.
So ketogenic diet during pregnancy, no. We can't do it. I don't know what happens. I've not actually had yet a patient on ketogenic diet who gets pregnant. So I'd have to review the literature to be on it because you have to wean it. And I don't think our nutritionist is here. I defer to Amanda quite a bit. Yeah. Okay. You kept her on it during pregnancy? Okay. That's not happened to me yet. So yeah, I have a, and she was okay? Okay, and the baby, yeah, I don't know. Okay, so look, you did. She answered it. So you can, but not to my knowledge. Not I don't know. That's the answer. Any other question? If not, I'll tell you what happened to my patient, my other patient. I never finished my case report.
We want to know.
You want to know? Do you want to know?
Is it
Are you asleep?
Two autistic kids.
It's a bit of a boring topic. I'm sorry. I was trying to make it a little bit like half asleep, but it is an important topic. So especially when you get the cases if you meet the people, I should have brought a patient maybe. But yeah, Chunip, we should have brought a patient. Maybe next time bring a patient. But
Someone DM you.
yeah, someone DM you. Or one of Heather's patients. But basically, so that patient came to me on Topamax, and just to finish that thought, I couldn't. You're right that I normally wouldn't change anyone. It's easier to do nothing, right? It's always easier to do nothing. But I really didn't like that other child and actually she had been dropped to a 25 Q day of topiramate with the previous pregnancy. And even with that, I can't rule out the fact that the topiramate caused the autism in her child, and that really bothered me. So we discussed it. I brought it up. I told her it's a really low dose. We could probably stop it, but I can't guarantee you're not gonna have seizures. I told her all the risks. And I told her we could just switch you to something that's safe. And so she finally agreed. We put her on levetiracetam. She was very upset with me because she was very cranky for the rest of her pregnancy, and her partner hated me even more. We added B6, which sometimes you guys do in pediatrics a lot. And there's not that much literature in the adult world, but for her, it worked. It was a miracle. B6 saved her life. So we gave her vitamin B6 with levetiracetam, saved her marriage, and she's still on levetiracetam. Actually, yeah, her husband was really upset with me. She was really irritable, crying, and then she was uncomfortable. She was pregnant. So anyway, but her child's fine as far as we know. It's been a year, so fingers crossed. But the other thing that's difficult is that I would be interested to do genetic testing in her other child to understand if there's a genetic mutation, is it really the medication? Is it not? There's a lot of questions that we don't know. But, we discussed, she was reasonable. You discussed it with the patient. I think it wouldn't have been crazy to stop it because she hadn't had seizures in many years. Her EEGs were normal. So some physicians might have, with the patient, decided not to treat her anymore. Because is it really necessary to be on an anti-seizure medication? I find levetiracetam very, 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 very safe. And we know that. Yeah, I know. But, we put on a really low dose too. I think she was on 250 BID. I put on a really low dose because she was on such a low dose. So, yeah. Yeah, so you worry about that. Someone asked me if there could have been some missed autistic traits in the parents. Yeah, so I didn't meet this second pregnancy was with a different father, so I didn't meet the first one. But there was no family history as far as we knew, because we asked that. There was no family history of epilepsy or autism or neurodevelopmental disorders. There's a lot of question as to what causes. We don't know, right? So usually we do genetic testing, but I'm not treating her child. And he's mild, like level 1. So, and she didn't want to have him tested now. So we'll see. But it's a good question. What's the cause of the autism? I don't know. A lot of questions. So the conclusion really is, whenever you meet someone who has epilepsy, look at their medications. I'm happy to send you any my slides if you want, or any of the reference articles that tell you which medications are safe or not. They should be on folic acid around 1 milligram. Really, you should counsel them about contraception. Some oral contraceptives are safe, but usually IUD is what we recommend for most of our patients. And in general, pregnancy is smooth. They need a lot of follow-up, but they are followed in high-risk pregnancy care typically, but most deliveries are vaginal deliveries. And then I think there's something else I wanted to mention, but I'm forgetting now. I forget. Anyway, any other questions? Or? Yeah, sure.
Is there a eclampsia issue correlation?
So it's different. So if you have new seizures in pregnancy, especially in the second trimester or third trimester, then you worry about eclampsia, and that can be in our epilepsy patients as well. So that's a very good question. And so let's say one of our patients is pregnant and then they go to the emergency room with a seizure. It's very important to question, is this your typical seizure? Because sometimes it's not, it's a different seizure, and then we have to rule out other causes. So yeah. But the new diagnosis in pregnancy, that usually they'll be treated with magnesium and like eclampsia if they meet criteria for eclampsia. Again, that's obstetrics. But then after that, we see them and we have to decide whether they have epilepsy or not. And the way we do that is after the pregnancy, when they're done with the obstetrical portion, we'll do EEGs, MRIs, and we'll do our usual questionnaire to see, do they have epilepsy or was it really related to the pregnancy? That takes time sometimes. No, so I mean, if they meet the criteria for eclampsia, like they have the high blood pressure, the protein in the urine, all that, they'll treat them with magnesium. They won't be treated with anti-seizure medication. But if they don't, they had a seizure, we treat them with anti-seizure medication, and then we'll reassess afterwards how long we treat them, depending on the EEG abnormalities, MRI, you know. But it's a good question.
Oh, no. There's no question.
Well, thank you very much for inviting us.